So we talk of the biomarkers in the sepsis. So do they really make a meaningful change in the ICU decision, especially in case of the sepsis? If you talk of the lactate trains, maybe the procalcitonin or the
Yeah,
CRP, are they decision drivers or just a supportive makers?
it depends on what kind of decision we're talking about. Now, let's maybe first look at the at the diagnosis. How helpful are they to diagnose sepsis? And I think the evidence base is quite solid there that PCT, CRP are not considered to be helpful to guide the initiation of antimicrobial therapy. Does it mean that so this means that if you just look at the value of PCT or CRP, it's useless. But of course, at least I in clinical practice, I look at multiple things, and biomarkers can be one of the things. For me, it's very important to first also know if you have any historical data to compare with. If you have like daily trends in biomarkers, that's much more informing compared to like a single value. I think single value when it comes to biomarkers are of little use. And of course, if you have a patient who's been in your ICU, has very low inflammatory mediators, CRP level, PCT level is low, and then the patient, something happens, the patient deteriorates, and then the biomarker goes up. Well, I would say, okay, do you need a biomarker to confirm, what you should have picked up clinically? If the FiO2 goes up, doubles, well, if then the biomarker doubles, of course, you look at your patient, you try to understand what is happening, and maybe a biomarker can point you to something, but to diagnose and to initiate antimicrobials, biomarkers up till now, I mean, this is the holy grail. This is something we're all looking for, and if you find it, give me a call. But this is not what biomarkers can be used for. At the other end, at the end of the treatment and trying to define when you can discontinue antibiotics, I think this is where biomarkers have probably the most solid evidence now, and indeed that PCT has been studied most extensively, that PCT, and again, trends in PCT, can help you to identify patients in whom you can stop antimicrobials. Typically, you will gain a few days of antimicrobial therapy, and the challenge still is, of course, to keep antibiotic therapy short, like 3 to 5 days. Most studies have shown that you can reduce antimicrobial therapy from 10 or 12 days up to 7 or 8. Then again, I would say that for the bulk of the infections we treat in the ICU, the evidence is already clear that you don't need 2 weeks of antibiotics for most of the infections. Okay, and I'm sure we'll say, well, osteomyelitis and ventriculitis and endocarditis, of course, there are exceptions, obviously, but the 80-90% of the infections we treat can still be treated with 7 days, and probably shorter, because why do we say 7 days? It gives us this feeling of completeness. 7 days is like 1 week, the circle is round, right? But there's no biological rationality. The pathogens have no idea what day of the week it is and how long they've been exposed to a certain antibiotic. So probably other solutions apply as well.
So you've answered the half of my next question, that is, how do we de-escalate and decide the duration, especially in the...
Yeah, well, they're linked. They are linked, unfortunately. Well, fortunately, unfortunately.
Yes. No, but
Biomarkers.
yes, yeah.
Yeah, and again, it's the decision to start antibiotics depends on the severity of illness, of course, of a patient. With a patient in shock and really factors indicating, even if you have not formal confirmation of infection, you would initiate antibiotics and still, of course, reevaluate. And it's the same for patients where you're not so sure and you do some extra investigations. This is... Yeah, you can still initiate antibiotics a few hours later, but that still should not keep you from trying to confirm or refute the diagnosis of infection. It's not because you start with antibiotics that you walk away and you go doing something else. That's not the idea. You start antibiotics, you keep looking for the source. If you're unable to find a source, and maybe 1 day later you say, well, I was wrong, and please note that this is something we all have difficulties with. Like, I took a wrong decision. It's hard to admit. But if you truly find an alternative diagnosis, if your patient has atelectasis or pulmonary embolism and not pneumonia, well, then you discontinue antibiotics. That's pretty straightforward.
Now we talk of the unique challenges the sepsis management faces in resource-limited setting, be it the diagnostics, delayed presentation, antimicrobial availability, ICU
Yeah.
constraint, and how outcomes can still be improved in those areas.
Yeah. Yeah, I understand, of course, that low resource settings are always more challenging, and admittedly, sometimes these interventions seem like difficult to implement. But at the same time, I think we've seen a number of interventions recently that also are applicable and more easily applicable in low resource settings, and maybe even more useful there. We've had the capillary refill time to guide resuscitation rather than maybe complex invasive cardiac monitoring tools or transesophageal echocardiography if you do not have an echo machine. Along the same lines, I do think, for instance, also continuous or extended infusion could also be an not so difficult to implement from a technological point of view procedure in lower resource settings. And please correct me if I'm wrong in that, but I think it may be a smart way or a relatively simple way to use antibiotics in a smarter way, rather than have to resort to these new and expensive and not easy to get antimicrobials. A smarter use of our current armamentarium may be the solutions. So I think there's also an increasing awareness of this among sepsis researchers and clinical researchers around the globe, that it's not only about considering what may work in your high-end institution in the US, but also think of more difficult, more challenging circumstances and what we can do for those patients.